people with depression and anxiety and can be very effective. Okay. In mind, oh, I answered the question here. It's now, you know who did these questions for us? Peter Buckley from Medical College, Georgia.
Yeah, well, he's a dean now. He's a little
He's like me. He's an educator, so he's slow on the science here. Okay. Relapse in schizophrenia is most often associated with A, noncompliance, B, later age onset, C, intense family involvement. Okay, A, non-compliance, non-adherence, number one problem.
You have to have some faith in your treatment, right, as a patient. Otherwise, non-compliance would have no effect.
Okay, which of the following medications is considered the mainstay of treatment-resistant schizophrenia?
B it is.
B it is. Okay.
Alan wants to make a comment.
Go ahead.
Is there a lot of clozapine use in the kingdom?
Yes.
And what are you using for long-term kinds of injectables? Do you have haloperidol? Or is it haloperidol? You have constant. And is that popular? It is. It is.
You don't have injectable paliperidone yet?
No, not yet.
Okay. I can tell you when you have it, it's better than constant. The patients like it better, and it lasts longer.
It's been very successful in the U.S.
Are we ready?
If I might add, you might wonder why there isn't an injectable quetiapine in terms of long-acting. And the reason is that the molecule is very efficacious but not very potent, which is why you have to give 300 to 600 milligrams. There's not a syringe big enough to load up a patient. You'd have to give them about 5 or 6 grams. Like 20 grams to last for a month. They'd have to have a backpack.
Okay. Weight gain is most likely to occur with which one of the following antipsychotic drugs?
It's actually C and D.
Yeah. Well, we have
No, this is Peter Buckley. It's C and D. They're really, if you look at all the available evidence, olanzapine has come out ahead in some studies, but really if you take the totality of available evidence, they're really almost identical.
Okay, well, this one says clozapine over olanzapine for the last HPA. Okay, this one's wrong. We won't get that slide. Okay, which one of the following has been shown to be most effective in reducing suicidal behavior? I'm not going to read the questions. Go for it.
D it is. D.
Remember that Intercept study? We showed the Intercept study, and it got FDA's FDA. You got clozapine FDA approval for the prevention of suicide.
Okay. The most common extrapyramidal side effect of antipsychotic medication is? They know.
A it is.
Okay, first line, atypical antipsychotic medications have clearly demonstrated identical side effects, excellent efficacy in treatment resistance,
I mean, this is
comparable
good,
efficacy,
spirited,
or efficacy
so I
against
would say
negative
support
symptoms.
guidelines and
Well, everything is comparable.
Well,
Want to say more equal,
it's-
C. Yeah. We have to rewrite these questions for you, Debbie.
I know, we get into this thing where we write them like we're writing for exams in the United States, and as I was
Let me disagree with Dr. Newcomer. So the problem has to do with the dose of the risperidone. So once you're getting above 2 milligrams, certainly heading up towards 4, the chance of having extrapyramidal side effects is considerable. On the other hand, a first episode psychotic break in a 17-year-old may well require more than 2 milligrams of risperidone. Sir.
If it's a female patient, yes, would you change your drug approach?
17. She's 17. She's post-pubertal. Yeah. Yeah.
I, I, yeah, I personally think the prolactin issue has been overblown, and it's more of a marketing issue than it is a real problem. And you know, what's interesting about the risperidone effect is what you end up doing is picking up a lot of pituitary microadenomas. So patients who have a pituitary tumor don't know it. You give them risperidone, and suddenly they're you know, having milk ejection, and they're showing breast enlargement, and then you do a scan and you pick up this tumor. But for most patients, it hasn't been a clinical issue.
Now, the other thing I want to say is that these are multiple choice questions. We have not given all the answers that are possible, and it's very nice to see that there's clinical differences in how people can approach the science here. The treatment of first episode schizophrenia differs in comparison to the treatment of chronic schizophrenia in that for first episode schizophrenia, patients are less sensitive to side effects. Comorbid disorders are less likely to impact adherence. Patients have, on average, lower response rates to medication. Patients tend to respond to lower doses of medication, or patients are more likely to adhere to atypical antipsychotics.
D.
I have to look for this one. D. That's right. Okay. A 28-year-old with schizophrenia is prescribed an atypical antipsychotic. A baseline fasting plasma glucose level is obtained and is within normal limits. How often, when would you repeat this test? At 3 months and then every quarter? 3 months and then once a year? 6 months and then once a year? Every 6 months, once a year? My sources say B, but
Yeah. So
what do you guys
so
say?
it's a great question, because the American Psychiatric Association, American Diabetes Association consensus guidelines said B. Okay, but in fact, there were other, the European Association for the Study of Diabetes and other groups in their consensus statements had said A. So actually, if you think about it, what we don't know in the clinical details of the patient are, is this the skinny, the lean patient at baseline, or is this patient already overweight or obese? If they're already overweight or obese, then they're more likely to have already had insulin resistance, already be working away at pancreatic beta cell reserve. So it's actually possible that within a mere 3 months, they could show hyperglycemia. If that's a lean, low BMI patient with no evidence of insulin resistance, the truth is you're probably wasting money to go ahead and get the glucose at 3 months. I'd probably wait 6. And then what's also worth commenting on is, based on what happens at that 3-month blood test, if it looks fine, and again the patient has not gained any weight, I'm very comfortable with just an annual follow-up. If the patient had a completely normal fasting glucose, and then at 3 months now has fasting glucose that's gone up by 10 points, and they've gained 10 kilos, I'm probably not going to wait a year to check it again.
Okay. You were right, it was the consensus statement. A 40-year-old patient is taking clozapine for treatment-resistant schizophrenia, assuming no abnormal laboratory results. After what period of time would it be most reasonable to reduce CBC monitoring to once a month? A, 3 months, B, 6 months, C, 12 months, D, 18 months, or E, 24 months? See, I heard it in the audience. What do you guys say?
Probably do a year, but you know how we're all plagued by our patient experiences. So I was treating the son of a VIP patient, and he was doing great on clozapine. I mean, literally fabulous. And he ended up developing a granulocytopenia 18 months into the treatment, and I had to admit him to the medical service. I mean, it was an emergency. So I'm pretty conservative about this.
Okay, according to the Katie trials, which antipsychotic medication had the lowest all-cause discontinuation rate? Olanzapine.
Olanzapine.
Correct.
Remember,
A.
remember it was olanzapine was the lowest.
Okay. 38-year-old female patient with schizophrenia has been treated with haloperidol and risperidone at different times in the past. Currently, she exhibits a non-rhythmical hyperkinetic movement disorder of the lips and the jaw. This movement disorder is most likely consistent with, that's right, the prevalence of metabolic syndrome in patients treated with antipsychotics for schizophrenia is A, over 40%, B, nearly 80%, C, under 15%, or D, unknown.
So I think the correct answer is A, but it's a bad question because it totally depends on the population that you're looking at. So I think they're basing it on some published results from the Katie study.
Yeah.
In which case it was almost 50%. It was between 40 and 50%.
Right, they're going for A.
Yeah.
Which of the following defines recovery in schizophrenia? Ratings of mild or less in positive symptoms, less in negative symptoms, appropriate role function, ability to perform day-to-day living tasks and social interactions with a peer outside the family at least once a week. All four of these criteria met concurrently for at least 2 years, or all of the above. All of the above.
Remember, we had a slide on this, and it was all of the above.
Okay. Now we move over to depression. Which of the following is the approximate current estimate of the composition of risk for the development of depression? 2/3 genetic, 1/3 environmental, 2/3 environmental, 1/3 genetic, 50-50, or we don't know enough.
Come on,
to
I
make
told
an
you
estimate.
this. Now make me proud. B. Bipolar would be A.
That's right.
Okay, that's a trick question. I made it up.
Okay, in a European study of 19,000 subjects, which of the following was more commonly seen than guilt in those with major depression?
This is Dr. Schatzberg's study, so I hope you get this one right.
A, chronic pain, B, hyperphagia, C, psychotic features, D, memory loss. And I think that should be hyperphagia, right?
Yes, with a G.
Right. A.
It is, Alan.
Dr. Schatzberg.
So in that study, there was 45% of patients, subjects who endorsed major depression had chronic pain. Defined as every day for 6 months, see a physician or take something for it. We thought that was pretty high, but that's what the numbers are. We did the same study in California in 4,000 subjects, and it was 54%. It's even higher in California, probably because of athletic injuries, things like that. But it's very, very common, and chronic pain is more common than many of the other depressive symptoms.
Okay. A woman is referred for treatment of chronic severe major depression. Which of the following treatment approaches is most likely to be associated with sustained improvement in her symptoms? A, antidepressant medication plus psychotherapy, psychotherapy alone, antidepressant. Good, thank you. Which of the following neurotransmitter systems has been implicated in the pathophysiology
Now, whoever
of
gets this
depression?
wrong isn't getting dinner, okay?
All of the above, very good. In the important clinical treatment trial, STAR-D, level 1 remission rates after up to 14 weeks of treatment with an SSRI citalopram were, and I'll let you look at the numbers, 18 to 23, 28 to 33, 48 to 53, and 68 to 73. B. You said it.
B it is.
Okay. A 46-year-old man is on citalopram 20 milligrams a day for a major depressive episode. After 4 weeks, he returns to his psychiatrist. No change in his symptoms or little change. Which of the following would be the most appropriate next step in the treatment? Increase to 40, discontinue and begin venlafaxine, continue but add lithium, continue and begin aripiprazole. Aripiprazole. It is A.
Yeah, I could probably live with B, right?
Isn't that your
I could
favorite
live with
drug?
B, but A is probably the more correct answer. Yeah. Well, the key word here is if little change. If he had had a 20% improvement in his symptoms, it would make more sense to increase the dose. The fact that he had no response at all makes B a reasonable answer.
If the patient's over 60, you have to be careful, obviously, for cardiac risk. So,
Okay. Studies support which of the following hypotheses for the disappointing remission rate with SSRI treatment of depression? Increase of 5-HT2 receptor density in the midbrain, increase in the number of serotonin transporter binding sites, stress decreases norepinephrine circuits in the CNS, or lack of effect on dopamine circuits. What do our experts say?
So the correct answer is probably D, the fact that SSRIs really have no effect on dopamine.
Right, that's what they think. And dopamine, as you said in your talk, has something to do with depression.
At high doses. So Alan just reminded me to mention that if you want to affect dopamine and you don't have MAOIs, which you don't, one way to do it is to increase sertraline's dose. As you increase the dose of sertraline, you start blocking dopamine uptake. And at 200 milligrams a day, sertraline is actually a reasonably potent dopamine reuptake blocker, so you end up with a serotonin and dopamine reuptake blockade. It's also why it's unusually effective in treating Parkinson's patients with depression, so you might want to think about that. Yes.
but most of the data is really adding an antagonist more so than an agonist. So there are agonists, there are pramipexole data and some other data.
There is data with both pramipexole and ropinirole. And I've used pramipexole on a number of occasions added to antidepressants to augment antidepressant response. There are 3 studies in bipolar depression that pramipexole added to SSRIs are effective in bipolar depression. So, and there's 1 study with ropinirole.
Okay, we're going to move on so we can finish up and get everyone to dinner. In bipolar disorder, psychotic features do not occur during which one of the following? That's,
A is
get to
correct.
dinner sooner. In addition to lithium, which one of the following is recommended as a first-line monotherapy for bipolar depression in the revised American Psychiatric Association practice guidelines?
D.
A. No?
It's 2002 is the problem. You're listing the god. We didn't have lamotrigine in 2002.
That's what the answer is.
Well, then it should be 2000 and some other year. The answer is A with the modern data. If it's 2002, it was the appropriate.
I see. Okay, well, we will fix that question. 34-year-old woman with bipolar disorder has a BMI of 31.2. To avoid weight gain, which of the following medications would be most appropriate? Yes. Okay.
Debbie, are these Joe Calabrese's questions?
You know something? They're not. I'm trying to think who did these.
Okay.
Can't remember.
We
Not
don't love,
Peter
we don't
Buck.
love these questions.
Which
Because
is-
remember that lamotrigine is not effective for treating rapid cycling bipolar disorder. So you would never pick lamotrigine
Oh,
in
this
this
one is-
case. And you probably, bupropion, maybe for the,
Well, no, this is weight gain. And that answer for weight gain is C, lamotrigine. Now, we're going on to the, you're answering this question. They say lamotrigine, and you disagree.
well, it says rapid cycling bipolar disorder. There's
And you
no
wouldn't treat
efficacy
it. Right.
for
So
lamotrigine.
this is, we throw this question away. This is wrong, wrong, wrong.
Okay.
Right? Okay, 25-year-old woman diagnosed with bipolar 1 disorder, previous history of several suicide attempts. Of the following medications, which would be most likely to decrease her risk for suicide on a long-term basis?
All right.
They got it. We're almost done here. Which treatments below have been shown to be effective for PTSD? They're better, you know, we did this in the United States and all the
All of the
psychiatrists got
above.
it wrong.
We didn't cover that.
All of the above, but
Correct.
cognitive behavioral therapy, very important. And that is it. Time. Thank you all very much for coming.
So now the floor is open for any question for any speakers of today's activity. We have almost 15, 20 minutes for that before dinner.
I have a small question. You were talking about the propensity of antipsychotics causing more tardive dyskinesia in bipolar patients. For what particular reason, Anna?
Oh, yes. So, yeah, if you look at antipsychotic drug exposure to schizophrenic patients and bipolar patients, it turns out that bipolar patients are significantly more liable to develop tardive dyskinesia. And the reason probably is that when you do MRI scans of their brains, they show these white matter hyperintensities, which are probably very small lacunar infarcts that they develop, more in the elderly than in young people. But the data is pretty clear in this regard. Schizophrenic patients, ironically, are relatively resistant to developing tardive dyskinesia, which is a good thing.
It's really an old observation, goes back even before bipolar, and John Cole and George Gardos published this in the late 70s, 80s, that the highest rates were older women with mood problems, actually mood disorder problems, even postmenopausal, had the highest rates in their studies. And now people have kind of moved to using the antipsychotics so commonly with bipolar. But you tend to see, in fact, I think more other side effects too. I think, in fact, the metabolic effects in bipolar with drugs like olanzapine are actually worse than in schizophrenia. If you look at the paper that they published on the long-term outcome that Ross Baldessarini published, patients started with BMIs of about 31. These were bipolar patients. They wound up after a year with BMIs of 35. I mean, that's a staggering, in fact, increase. And they tend to be older. They've been on drugs for a lot longer. They tend to have gained weight from all sorts of medications. And then you add in a drug like olanzapine, and you really kind of push them over. Yes, please.
Let me just add one more comment.
Hi, because we didn't talk to John, is that thank you very much for very nice educational presentations overall. And my question is that what to do if a bipolar patient becomes pregnant, and what will be the choice?
So that's a great question. It happens all the time. And I'll just tell you an anecdote. So I was at Duke University, and I was treating a woman who married to a very successful farmer. She had 2 children, 39 years old, and she had pretty bad bipolar disorder. I had hospitalized her 3 times. And she and her husband came to me and informed me that she was pregnant and she wanted to come off of all of her medicines, which at the time were lithium and valproate and a typical antipsychotic, thiothiazide. And I spent hours with this family. And she absolutely was adamant, and her husband promised me that he was going to watch her very carefully. And at the first sign of any mood instability, that he would contact me. And one winter night, 7 months into the pregnancy, she had an abrupt manic episode. She was found dead, frozen, outside in a farm pond. Lost her child. So that event really affected me as a young psychiatrist. And so since that time, what I've done is to try to manage pregnant women with the minimal amount of medication in the first trimester, because that's when organogenesis is being developed. And try to plan the pregnancy so I can take women off the medications that they're on. We know very little about atypical antipsychotics because pharmaceutical companies are so concerned about liability, they don't want to study pregnant women. So what I tend to do is try to keep them minimally treated. You try to use bupropion as an antidepressant if I have to, because it has the safest record. Use lamotrigine because it's the safest of the so-called mood stabilizers, and use sertraline because it's the best study of the SSRIs.
That's a very that's a very good question. I'll give you a kind of another anecdote about this. I had a similar kind of situation. It's a patient and her husband's a lawyer, and she had 1 child, wanted to have another child. So we got into this about 30 years ago, 25 years ago, the discussion about what the risk was of having a kid and whether having bipolar disorder, etc. She was a bipolar 1. She was a lawyer by training as well. And she decided she wanted to get pregnant, and we took her off. She was on lithium at that point. And we agreed as to what we would do, that we would basically hospitalize her if she got manic and try to not treat her with meds throughout the course of the pregnancy. Well, she got through the whole pregnancy. This is an interesting story. She did it very well. She has the child. Her obstetrician comes into the bedroom after the child is born, and he says, "Why don't resume your meds? And because you can breastfeed, and you've done well." Within 48 hours, she was in an absolutely profound psychotic depression. I mean, she, just with the drop in her estrogen levels, became profoundly depressed. And I got a call from the husband saying, "What are we going to do?" So we resumed the lithium, and within 48 hours she came out of it. The interesting thing about the worry about having the second child and the risk, she had 1 child at that point, having the second child. It turned out the second child actually probably has developed bipolar disorder.
Yeah.
The first one had, I'm sorry, the first one has bipolar disorder. The second one it doesn't. But one of the things I think to add to Charlie's recommendation is probably lithium is actually quite a good drug here. We got scared off with the cardiac risk, and if you look now at the numbers that have been generated, that came out of Australia, that the largest studies out of Canada and other places have shown that the risk of Epstein's kinds of anomaly are extremely low. They're in 1 in 10 to 20,000, much lower than was originally reported, which was around 1%. So probably lithium may be actually the safest kind of thing to use. The scary drug, to me, is valproate, because we used to use valproate, we used to give patients folate, avoid trying the spina bifida and tubular defects, and then what we have now is these risks for really kind of lower IQ, lower verbal memory kind of performance. So I think lithium probably may be the best bet that we ought to go back to, because we really got scared off, and I think I'm most scared off by some of these other medications. Yes.
Dr. Allen, do we have any relative or absolute contraindication for Neurostar TMS? And when you prefer to give it, to give ECT to it, what about patients with pacemakers?
Charlie said, you know, there are other RTMS device manufacturers that have in the process of filing for approval, but none of them are approved for treatment. They're going to be approved for stimulating, try to find peripheral nerve problems, etc. There's no particular counterindication that I know of for giving RTMS. Cardiac pacemakers, there are no problems. It's very, very localized kinds of energy. Oh, well, maybe it's a relative. It's a relative risk. It's not that. Yeah. Right. So there really may be epilepsy, but even that, I don't think it's the actual kind of.
No one knows because they were excluded from the trial.
But if there's a worry about focal kind of, epilepsy, you might worry about it. But other than that, it's really been quite benign. We have not seen a problem with it. We've treated all sorts of patients. One of the issues is if somebody has, in fact, shrapnel or something like that, can they get RTMS? I don't know, because it is a magnet, and probably you want to exclude somebody who's got some sort of metal plate or whatever. But I'm not sure that that's something that's even in the FDA package. It's pretty safe. It's not intracardiac, intracerebral, kinds of hydrocephalus are, not necessarily contraindications either, from what I've gathered.
Do you advise us to replace ECG with this?
No. I don't think we were talking about that. I don't think it has comparable efficacy. I think you're looking at it as a refractory depression tool, ambulatory basis, milder depressives, not psychotic, who are refractory. It is not for the acutely suicidal, psychotically depressed person. There was one small study in psychotic depression that showed it had no effect. It's really kind of a more of an alternative to SSRIs plus or SSRIs plus. It's the non-delusional refractory patient. It's not an equivalent of ECT. One of the things that has been raised is whether you can in fact use it for maintenance. So, one of the big problems we have in the U.S. is we're using more and more bilateral ECT, and when you get into maintenance ECT bilaterally, you have a real problem because you get more and more cognitive effects. What needs to be studied is a randomized trial of acute ECT followed by maintenance with RTMS versus maintenance ECT. That would be very informative for the field, because if that worked, then we would in fact be able to use it for long-term prevention, but it's not a substitute for ECT.
I think it's a interesting new member of our treatment team, this device. But Alan knows what I'm going to say. It was approved by the FDA for patients who failed one, but not more than one SSRI treatment. In the patients who had failed more than one, it didn't separate from sham treatment. So the sense has been it's not really effective in really refractory patients. Secondly, the company that manufactures it has not invested in additional large-scale clinical trials to help inform us. So all the studies Alan is talking about, post-ECT, subtypes of depression, the company has refused to invest in. And I don't view that as being, excuse me, a good healthcare partner. Pharmaceutical companies invest large amount of funds in clinical trials. Device companies should do the same.
Dr. Ali Akram, for mood stabilizer, if the patient continue in the mood stabilizer or mood stabilizer and atypical antipsychotic, and after many years, for example, 5 years, 10 years, and no episodes, the patient must be continued for all his life or can stop?
Actually, there is many factors that give us the idea about how long or how much I can be, I have the courage to stop the medication. For example, if this patient is a difficult bipolar patient before, I have one patient that has rapid cycling bipolar disorder, and this patient is now stabilized on both mood stabilizer and antipsychotic for around 3 or 4 years. To be honest, I never think to change my regimen, because this patient, the history give me that he was a rapid cycling and his manic episode was very aggressive and even threatening, life-threatening. So I didn't actually think. But if the episode was mild and he has no past history of many episodes, you may try to withdraw and to keep him on monotherapy as much as you can. So other factors may control the story.
I would agree. I think the truth is I've seen probably about 5 or 10 patients in my career who had one manic episode, a bad episode, not a rapid cycler, but had a bad episode, say at age 25. And you treat them and they're now 35. And they come to you and say, I haven't had a depression or a mania in 10 years. I've been taking lithium or whatever. Don't you think it's time to try? And the fact of the matter is it's very rare for a bipolar patient to have one episode in 10 years. So either they had a great response to your treatment or they're sort of an anomaly. And I think it's worthwhile doing exactly what you suggest, which is work with the patient, lower the dose, be very vigilant, hyper-vigilant for any symptoms, tell the family members, and see. But I have had patients, I'm sure you have too, that have had one episode in their life and never had another episode. I don't know what to make of those patients.
This is another question I want also to ask. If there is any explanation why some atypical antipsychotics can be suitable as prophylaxis against depression and other are not. For example, aripiprazole is effective as an augmenting for the major depression, but it's not fit for bipolar depression. And at the same time, the use of antidepressant in bipolar patients. Some patients can respond quite well on the antidepressants. Others are very resistant to antidepressant in bipolar depression. And there is a very big debate and controversy and even meta-analysis that contradict each other in those patients. If there is any explanation for this puzzle?
We don't have enough data on the prevention of depressive episodes. And so one of the great, we do in terms of SSRIs, and what we know is if you respond to an SSRI and you stay on it, it has a relatively low relapse rate, and if you come off of it, it has a high relapse rate. There's no data, no really good long-term data on atypicals in this regard. So I'm not aware of any data, maybe you are, in which patients who are treated with olanzapine or quetiapine for depression, not talking about for schizophrenia, but for depression, and then determine whether long-term treatment would protect them from recurrence. Are you, Alan? I just don't think that data exists.
It's obviously an area that needs to be